Hi everyone, welcome to ResearchMD.com. We got a great morning report case today. So again, my name is Pramil. Cheriyath. I'm a program director, internal medicine residency, transitional residency in the United States. I teach medical students and residents on a regular basis. Assistant professor of medicine, 2 large medical schools. So we've been doing a series of morning reports. So please join us today and let's hear about the case.
There's a 70-year-old male.
We got a 70-year-old male
Who presented to the emergency room for evaluation of bradycardia.
Now, you just have to be careful when you say like it's. I mean, when you present and attending, right? Don't say like the patient is going to say I got bradycardia. No, right? So I'm just going to be tough with you all. Like, I mean, this is what kind of first thing really upset with me. We need to know what, I mean, you know, when you talk about history of presenting illness, try to express in what the patient is saying so we can come up with a diagnosis. Now you give me a diagnosis already and I don't like that. Okay, so tell me, what was the patient complaint?
Yeah, so patient was actually transferred from the nursing facility because they found out that his heart rate was very low.
Okay. So he was at a nursing home, they found out his heart rate was low, then he was kind of transferred over here, and then we know it's like bradycardia, correct?
Yes.
Okay, so when you say like everything, when I say about when you present it, what's the first thing I always ask? What's the emergency, right? What is the emergency over here? How do you handle it? Of course, bradycardia, arrhythmia, sudden death is very common, okay? So first thing we have to do, make sure the patient is stable, okay? Make sure the vital signs are stable. Right? Then you get an EKG. Let's say the heart rate is persistently kind of low and hemodynamically unstable. Which drug we should use?
Atropine.
Atropine. Okay. It's good to know the dosage also. Before even doing that, I put the transcutaneous pacer on the temporary pacemaker on the side. Temporary pacemaker pads we can use. Okay. So when you look at the atropine, the dose you can use is like, it's like 0.5 milligram and you repeat it like every 3 to 5 minutes. You can give like how much max, like 3 milligram, you can do up to 6 doses, okay? And then if it doesn't work, then you have to think about like dopamine, you can give like IV infusion, usually like 2 to 20 microgram per kg per minute. And if it doesn't work, you can try epinephrine, again 2 to 10 microgram per minute. This is like IV infusion. There's also a role for isoproterenol, okay? All of this thing, and then again, don't put the pacemaker, temporary pacemaker, and all those kind of things need to be done. So always rule out the emergency to make sure the patient is stable. Now, let's go and talk about the differential diagnosis of bradycardia when somebody coming in, right? So what is the number one cause in the United States, somebody with the bradycardia? Anybody? It's cardiac conduction defect. So we'll start with the cardiac causes, okay? Cardiac causes, we'll say conduction defect. What else? What else is in the cardiac cause?
Congenital causes.
Let's look at the other, like more serious. Could be an MI can cause? Yeah, definitely, right? MI, right? What else?
Any myopathies?
Cardiomyopathy, yes. And then what else? Keep talking. What about surgery? Can like a cabbage and all that can cause? Right?
Yes.
Any kind of surgical kind of thing. What else can cause? You said myocarditis, right? Myocarditis. Okay, several things can cause. And then, what are some infiltrative disorders of the heart? Can somebody tell me, like that can cause like
Amyloidosis.
Amyloidosis, yeah. Let's say infiltrative disorders of the heart.
Hemochromatosis.
Amyloidosis. Hemochromatosis. What about sarcoidosis? Very common, right?
Yes.
Sarcoidosis. Okay, a lot of things. Of course, congenital heart disease. You got what is the other one? Six sinus syndrome, right? We didn't talk about that. That also come in the conduction kind of pathway, right? Remember, six sinus syndrome and all that kind of. Anytime, let's say you have like post cardiac, like CABG or valvular surgery also. I remember. Okay, so we covered all that. What are the other causes? Like, let's look at the respiratory causes. Somebody, what are the respiratory causes? Can hypoxia causes, right? Let's say hypoxia, right? That can arrhythmia, hypercarbia, okay? And then you got sleep disorders, right? Sleep apnea,
Yes.
okay? And then what are the other electrolyte abnormalities, right? We just that's also very common. So what are the electrolyte abnormalities we have to worry about?
Hyperkalemia.
Hyperkalemia. Okay. What else? Increased magnesium also. Hypermagnesemia. Okay. That can also kind of things. What about glucose? Can it be low glucose hypoglycemia? Right. So that can also cause us decreased glucose. So those are the major electrolyte. What about endocrine causes? What are the endocrine causes we have to worry about? Somebody tell me.
Thyroid.
Thyroid. Which one?
Hypothyroidism.
Hypo, okay? Hypothyroidism is kind of very common and all that too. And we talk about the electrolytes, and what about, let's talk about infectious causes. What are the infectious causes? Main thing we have to worry in the United States, no?
Lyme's.
Lyme disease, always, there's a lot of ticks out there, depends upon the season, everywhere. I think New Jersey is the capital of Lyme disease in the world. So Lyme, what else? What are the other infection diseases? Syphilis, right? That can cause sexually transmitted diseases also. Syphilis.
Typhoid.
Typhoid fever, yep. Remember we talked about relative bradycardia before,
Yes.
right? So typhoid fever, you got the fever and the temperature actually comes. So relative bradycardia is very common. Anything else? Legionella can cause it, right? And then Chagas disease.
Diphtheria.
Huh?
Diphtheria.
Which one?
Diphtheria.
Diphtheria. Okay. Chagas disease, very common, right?
Yes.
Okay, so we talk about endocrine, we talk about cardiac, we talk about electrolytes. Any other autoimmune diseases? Let's talk about autoimmune. Can SLE causes it?
Yes.
Right? What else? I guess sarcoidosis, we can say that too, right? Okay. What else could be the other? Polymyositis, right? Scleroderma. Okay, all of this can cause us like bradycardia. Okay, what about raised intracranial pressure? Can it cause? Right?
Yes.
Increased ICP. Let's say neurological causes, right? Neurology, increased ICP. So we got like a huge differential diagnosis right here. So tell me a little bit about this. Now we need to know, is this patient having any symptoms or anything, right? That's what we need to know.
Right.
This is like asymptomatic, so tell me a little bit about, was he having any symptoms?
No, patient didn't have any other symptoms.
Okay, what kind of symptom? Also, what kind of questions we need to ask? Somebody tell me. What do you ask when somebody with bradycardia? Are you having, number one, most of these people present with what? Syncope. Okay, like around 30%. You need to know about dizziness, right? Maybe like some palpitations or like, those kind of arrhythmia kind of causing and all of this kind of thing we need to know, right? Chest pain, right? We need to know those kind of symptoms. We need to know about a rash.
Yes.
Right? Lyme disease, we already kind of talked about it, right? So all of this, when you ask the history, we need to know. So tell me about the past medical history of this patient. So I'm assuming this patient didn't have any of that, right?
No, patient.
Okay, tell me the past medical history on this patient.
Past medical, the patient has hypertension,
Hypertension, okay?
hyperlipidemia, thyroid disease,
Thyroid disease.
and atrial fibrillation.
Thyroid disease and atrial fibrillation, right? Okay, he said thyroid disease. Am I happy with that presentation? He says a past medical history of thyroid disease. That's a good way to present to an attendee.
Should be specific.
Yeah, you have to be very specific. I've seen these people, residents doing all the time. Don't do that. I need to know it's hypothyroidism or hyperthyroidism, right? We need to know that. So what is make sure you go back and find out what is the patient getting and all that. We need to know we know this patient have atrial fibrillation, that's very significant. Okay, family history, is it important? What are we looking for in the family history?
Any congenital?
Yeah, any kind of congenital disorders. What about history of sudden cardiac death, right? We need to know that. Sudden cardiac death, right? That's more important. What about surgical history? Is it important to us?
Yes.
Okay. Why should we worry about surgical history? Why should we worry? We just already talked about it, right? What happens in the surgical history? Somebody have cabbage, right? We talk about cabbage, valvular disorders, right? Any of those things can cause us, so it's very important, right? Your surgical history. Okay, what about medication? Tell me what medicine the patient is on.
The patient is on atorvastatin, furosemide, and lisinopril.
Statin, furosemide,
and lisinopril.
and lisinopril.
Right.
Okay, so we need to know the medication. What are the medication we need to know? That's the most important thing, right? Which we did not talk
Yes.
in our differential diagnosis, right? It's very important to talk about medications which we forgot to talk about, right?
Yes.
What are the medications we need to know?
Beta blockers.
Beta blocker is very important, okay? Beta blocker, okay. And how do you treat beta blocker toxicity? Somebody tell me. You just glucagon 5 milligram every 10 minutes. So remember the antidote for beta blocker toxicity. Okay. And then calcium channel blocker, right?
Yes.
Calcium channel blocker. So how do you treat calcium channel blocker toxicity? How do you treat that? You give calcium gluconate or you can give insulin. That's the way to do. And then we need to know, do we need to know any of the pain medication? Right?
Yes.
Opioids, right? How do you treat opioid? You give an naloxone, right? So those kind of things we need to know. Digoxin can cause us, right?
Yes. Even amiodarone.
Amiodarone. Plenty of there's so many medications over there can cause us, right?
Yes.
And then flecainide, sotalol, and all those amitriptyline, lithium, and all of those medication can cause us. So it's very important about the medication. Okay, don't forget it. So we did medication. Let's talk about social history,
Yes.
right? Okay. What else? What kind of history we need now? Social history.
The
Smoking.
patient is not a smoker.
Alcohol. Why is it alcohol is important to us? Cardiomyopathy, right?
Yes.
Alcohol cardiomyopathy. So does he drink alcohol?
No, he does not
Okay.
drink alcohol.
All right. Do we need to know about his exercise habits? Right? Did you ask that? Why is it important? Physiological bradycardia,
Yes.
right? That's another differential diagnosis we have to think, right? If this guy, if he's running I don't know, maybe 24 miles per day, very athletic and all that, they can have physiological bradycardia. I've seen people with a rate of 40, and that's what they kind of live on, right? It's very important to ask them. Okay, sexual history is important or what?
Yes.
Why is that?
Infectious causes.
Syphilis.
We talk about infections,
Yes.
right? We need to worry about what infections we talk about?
Syphilis, chlamydia.
Syphilis, right? Those kind of things we need to know, any of those infection cause bradycardia infections. Okay. Psychiatric history, right? Any of them, maybe some of the psychiatric medication, which amitriptyline is very common. Okay. Lithium, amitriptyline, lithium. So psych history is we need to important. Because of the medication, right?
Yes.
Okay. Now, so everybody got it. We just talked about all the differential diagnosis. Let's talk about vital signs. Give me the vital signs.
Patient's blood pressure is 120/80. Temperature is 98.9. Pulse is 36. Respiratory rate is 18. Saturation is 95%.
95%. Okay. Why is the temperature important to us?
Any infectious causes?
Yeah, infection, okay, we talk about infection, those kind of things is important, but what else? What is hypothermia? Does it cause bradycardia? What's the classic finding they can ask in hypothermia? Osborne wave. Okay, remember, like the J point, they mean you're gonna have a hub in the near the J point. So always remember, hypothermia, Osborne wave. Okay, so that's another examination question you can ask. Okay, and the exam, anything positive?
No. The patient.
Everything was pretty much.
Everything was.
Okay, let's go to the labs. What labs
Yes.
are important to us in this patient?
CBC.
CBC and
Okay, CBC, electrolytes.
Yes.
Yeah.
Of course, potassium is important, right? What else? Even arrhythmia, like you have like renal failure, right? Then you have
Yes.
metabolic acidosis and all those kind of things. We need to know CBC. What else would you check in this patient? Do we need to know about cardiac markers?
Yes.
Yes.
Yep. We need to know troponin, BNP to make sure a patient is not in heart failure and all that. What else we need to know? Maybe an ESR, maybe like a lot of autoimmune disease, right? What else we need to? What else would you check?
EKG.
No, we're still in the lab, boss. Okay. What are the other labs? Do we need to know? Come on.
Magnesium.
Huh?
Magnesium.
Magnesium we need to check. Okay, I'll check the calcium also.
Yes.
Okay. What about TSH? No one told me
Yes,
about that.
TSH.
TSH is important to us? Okay, check TSH. What else?
Mm.
ESR CRP. For line titer, right?
Yes.
How do you check for line titer? What's the first test you have to do?
Mm.
You check for ELISA.
ELISA.
What's the sensitivity and specificity for that? It's pretty high, right? 80 to 90%. So 80 is sensitivity, 80 and sensitivity specificity, almost like 90%. Okay. If it is negative, you don't have to do anything. You can say rule out the other cause. If it is positive, right? If the symptom is like less than 30, then you have to do the IgG and IgM. Okay. If the symptoms mean more than 30 days, then you just do the IgG. Remember that. Lyme titer, we'll make another topic about Lyme disease, but it's important to check Lyme titer on somebody with a bradycardia. Okay. Anything else? Any other labs we need to know we forgot?
Mm.
If the patient is on like, any of the medication, you can check the digoxin level or any of those kind of things we can do, right? Okay, so tell me the lab. What are the labs in this
Yes.
patient?
Patient's WBC is 6.6.
Uh-huh.
Hemoglobin is 15. Platelet is 140.
Platelet is 140. Okay, sodium, potassium.
Sodium is 135.
Uh-huh.
Potassium is 3.7.
Uh-huh.
Chloride is 100.
Uh-huh.
Bicarb is 27.
Uh-huh.
BUN is 14.
Uh-huh.
And creatinine is 0.9.
Okay, 0.9. Okay, do we know about the blood sugar?
Yes, it is 94.
94.
Uh,
Okay,
also-
any other? Did we check the troponin was normal?
Yes.
Okay,
We also did a few others.
Okay.
Magnesium was 2.1.
magnesium was 2.1, that's normal.
Yes. Calcium was 9.
Calcium was 9, that was normal.
We also did MCV and it was 106.
106. Okay, so we know there is like what? Macrocytosis, right?
Yes.
We'll come back to that. But we didn't check any of those. TSH was checked?
No.
You think it's important?
Yes.
Yeah, very important. This patient with thyroid disease, we don't even know. You didn't tell me you didn't tell me he was taking like levothyroxine, any of the thyroid supplement also. Maybe you need to go back and check. And what's the other investigations we have to do?
EKG.
EKG. What is the EKG finding?
There was a second degree AV block, type 1.
Second degree AV block.
Type 1.
Morbid
Type 1.
type.
Morbid's type.
Morbus type 1. So somebody tell me what is the usual finding in Morbus type 1?
There's a progressive PR interval.
Progressive PR interval until the P wave is completely blocked. Right? So that is like a Morbus type 1. Alright, so we know only thing we know is like Morbus type 2 AV block. Any other investigation we have to do? Not really. I think so. What is our diagnosis? Right? Somebody tell me what's our diagnosis. We can say second degree AV block, right? Second degree AV block. Second type 1, right?
Yes.
Okay. Causing bradycardia, correct? Yes. Right? What is the next thing? I say hemodynamically stable, right? How do you
Yes.
treat it?
Treat the root cause.
Yeah. So we just kind of wait for all these other tests to do and kind of make sure and all of that. And then I will say like cardiology consult. Okay, I mean, in second degree it's kind of pretty stable. You don't need to like invasive like a pacemaker or none of this kind of indicator, right? So everybody got that. We call a cardiology consult. We'll make sure like, atropine, I'll just say atropine ready just in case. I'll write an order, atropine at bedside, right? At bedside. And then pacemaker pad just in case. When I write the orders, I put all this in just in case. I'm making sure nothing else kind of going on. Okay, what is the other thing in this patient? I mean, let's say anything else we can learn from. Why is this patient have microcytosis? Macrocytosis, right?
Yes.
MCV 106. Somebody tell me what is this patient? Why is this patient having macrocytosis? Thyroid disease can cause this macrocytosis?
Yes.
Okay, we didn't see any of the medication.
Right.
Those kind of things, we have to see. I mean, we can pretty much estimate probably thyroid disease. This patient had history of thyroid disease. We'll just wait for the TSH. Okay, and then if it is kind of normal, and then we can do the other investigations like vitamin B. But there's no anemia pretty sick. Hemoglobin is like 15. Maybe like an outpatient basis we can do setup. Okay, so it's a very important topic today. Bradycardia. Think about all the first thing when you come to bradycardia. Think about what is the emergency, right? This could kill the patient. Then you have to think about the role of atropine. It doesn't work, then you have to, always you have to make sure the pacemaker pads are ready to go. Then you talk about, dopamine, epinephrine, and isoprol, and all of those medicine, and then talk about all of our differential cardiac causes. Cardiac conduction defect is almost like around 50%, okay? And then we talk about respiratory causes, electrolyte causes. Always don't forget the medication. That's around I think medication is like 5 to 10% of the people usually presented, right? And then infection, don't forget the Lyme disease, right? You do the ELISA test first, and then if it is positive, then you do the IgG, IgM based on how long the symptoms were, okay? And digoxin can also cause autoimmune diseases like SLE. Make sure you examine the patient also for the rashes. Make sure you read about, all the block, and this patient have like type 1. Second degree blocks type 1. Okay. Thank you so much for watching. We'll be back with another presentation soon. Please, if you have any questions or comments about our diagnosis and the management, please put it under comment section. So let's make it a discussion so we all can learn from each other. Okay. Thank you so much. We'll be back with another presentation. Please subscribe to our channel. Thank you.